So good morning, everyone, and thank you very much for the welcome this morning. And my name is Joan Duncan. You've just sort of heard a bit about my background. So really, just then, my task this morning is just to address this statement from the perspective of Northern Ireland. And to do this, I'm going to provide a little bit of information on Northern Ireland to set out the context before outlining children's palliative care policy and the impact this then has on the lives of our children with life-shortening conditions and their families. Okay. So moving on, just to have a look to set it in context, the demographic statistics. In Northern Ireland, our total population is 1.82 million. We have 435,500 children, approximately between the ages of 0 to 15 years. We have approximately 1,300 children and young people with life-limiting conditions that we're aware of. We have approximately 500 children and young people with complex health needs who also have life-limiting conditions. And we have approximately 150 child deaths every year. So Northern Ireland, then, just to explain, is a devolved government area of the United Kingdom. The health policy within Northern Ireland is the responsibility of our Northern Ireland Assembly. We also have the Health and Social Care Board, and they're responsible for commissioning services. The Public Health Agency is then responsible for providing professional input to the commissioning process to commission those services. So if you have a look just at the map on the screen there, sort of within the colours, there are a total of 6 health and social care trusts within Northern Ireland. 5 of those provide integrated health and social care services across Northern Ireland, and the sixth trust is the Northern Ireland Ambulance Services, so there are 6 in total. So thinking, I suppose, then about children-specific services, we have a regional tertiary children's hospital and a regional neonatal unit, which are both based in Belfast, and that's where the largest area of the population would be within Northern Ireland. I suppose probably maybe similar to the south, we have pockets of rural and urban, depending on each of the trusts. The Western Trust and the Southern Trust would have the lower populations and more sparsely diverse. So across the 5 trusts then, there are 7 children's wards in District General Hospital, providing care outside of that regional tertiary children's hospital. So looking then at current service delivery for children with palliative care needs. So this slide is really depicting the professionals and the services who contribute to the care of children with palliative needs in Northern Ireland. And obviously the child and the family are at the centre of that, of all care services and delivery. So in Northern Ireland, the core services who support them are, down at the bottom in red, are the community children's nursing teams. This involves teams of registered children's nurses and healthcare assistants, and they deliver care to the children from birth right up until 18 years, sometimes 19 years if the children are still at special schools at that stage. We also have specialist nurses, and I suppose, for example, of that, maybe cystic fibrosis, the long-term ventilation respiratory team. We have multi-professional teams of allied health professionals and doctors who are often located in child development centres throughout Northern Ireland. The medical oversight is provided by consultant paediatricians, and just off note there, Northern Ireland is one of the few areas of the UK who doesn't have a children's palliative care consultant in post, but you're very fortunate in the south to have that post already there. We would welcome that very much. The Northern Ireland Children's Hospice provides specialist palliative care support across the region through community-based hospice at home services and also in-house support, and that's right across the 5 trusts. I suppose just maybe a special mention there of school as well. Some of the trusts will have community children's nurses based in special schools for the children's health needs. In my own trust, in the Northern Trust, we have a jointly funded post with the Education Authority who support children with life-limiting conditions to attend school, and we find that does increase their attendance at school. So, moving on then to have a look at the policy context. First of all, right back to 2011, we had Transforming Your Care. This was a major review of the HSC and concluded that the current system wasn't fit for purpose. There was an unassailable case for change right back in 2011. It identified a mismatch between the need for a proactive model based on prevention and the needs of the patients and the reality of a system based on hospital care, mainly hospital care. The report called for a major shift in the design of services, and there were 99 recommendations, and I suppose this would have been known as the Compton Review right back then. And I suppose that the key thing was a shift left, and that was a shift from hospital-based services right out into community. So Health and Wellbeing 2026 was published in October 16, and that was a report by Professor Rafael Bengoa. This report called for the development of an accountable healthcare system that aimed to manage people's health and to keep them well. And it also concluded that the current system had the capability to deliver on the key objectives, but would in reality take about 10 years to do so. Interestingly, the 12-month progress report has just been published with an emphasis on the development of a paediatric network led by the Public Health Agency. And unfortunately, you can say a year on, this is still in its infancy and is yet to have any focus on paediatric palliative care. So developing service then for children with complex health needs. This was published way back in 2009, and this was really the blueprint for our current Northern Ireland service model, and also led to the development of our Northern Ireland Paediatric Nursing Assessment Tool. This study recognised there were a cohort of children with life-limiting conditions living in all areas of Northern Ireland, and it also recognised the cohort of children who were technology dependent, requiring strategic planning to enable them to be supported to live at home. So then in November 2016, a strategy for paediatric healthcare services provided in hospitals and the community was published. And this strategy was designed to modernise and further improve the standard of treatment and care provided by hospital or community settings and palliative and end-of-life care for children and their families. So alongside that, we had a separate strategy for children's palliative and end-of-life strategy. It was launched in November 2016 by our then Health Minister for Northern Ireland. The strategy was well developed and thought out, and it included consultation with focus groups with children, families and also healthcare professionals throughout each health and social care trust in Northern Ireland, also royal colleges and representative bodies, voluntary and community sector, educational sector and district councils. So with this strategy, children, families and healthcare professionals are fully signed up to the recommendations within the strategy. So I'm just going to maybe talk a wee bit more about that. So the main aim of the strategy, as you can see, was that no matter what the circumstances, every child deserves the best possible start in life and the support they need to achieve their full potential, from pre-birth up to young people in their late teens. This strategy encompasses everyone who requires paediatric palliative support and those who are approaching their end of life. So the key elements then of our strategy are, as you can see, high quality, safe, sustainable, appropriate palliative and end-of-life care focused on ensuring the best outcomes for the child and family. And there were 23 objectives linked to a new care model. So then looking at the components of the new care model was very much around support for families. And just an example of that, I suppose it was in my own Health and Social Care Trust, investment has been made in psychology services, currently focusing on supporting infants who are inpatients in the neonatal unit and children and young people with complex health needs and their families, many of whom have palliative care needs. This service is really in its infancy and isn't spread across Northern Ireland, but it's a very welcome service. So obviously, holistic assessment and planning right across, multi-professional, about care being delivered in the right care, right place and at the right time for the children and families. Transition to adult services is definitely an issue within Northern Ireland. That crossover, we've a lot of work supposed to do on transitioning. Looking at end-of-life care, the bulk of that care is delivered by the Community Children's Nursing Services. It no longer in hospital, which I suppose is a development for us. Most of the end-of-life care either happens at home or in the Northern Ireland Children's Hospice. Bereavement care then around, I suppose, at end-of-life and post-bereavement care is also carried out by a range of multi-professionals. So enabling the new model then. So how do we enable the new model? Well, clinical leadership, I suppose, is the first thing. We haven't had a sitting assembly in Northern Ireland since January 2017. So therefore, we have no health minister since January 2017, and we also have no paediatric palliative care consultant. So those would be the key components of the clinical leadership to drive that. Looking at the networked approach, currently we have a Northern Ireland Paediatric Palliative Care Specialist Interest Group. All trusts have representation, including the Northern Ireland Children's Hospice, but that group really doesn't have any power to lobby or make changes. We're not on the current government agenda. There's no network to lead and drive changes. So within this, how can we improve access to services or improve the quality of service delivery? Workforce development training. There is a national shortage of children's nurses. The field of community children's nurses delivering palliative care services to children and families is recognised as very stressful, often leading to burnout. We're hopeful that the clinical psychology for staff will help to build resilience in my trust area, but it's not widespread, as I said, across the region. So we need responsive commissioning. Quite often we always seem to be firefighting and the cart after the horse on many occasions. So really then back to the question, does good policy on its own make a difference? Well, I suppose the answer to that is clearly no, and that's the challenge that faces us if strategies are not implemented and resources are not made available to implement change or recommendations followed through. Northern Ireland has a history of slow change. The transformation agenda has a long history, and I've already alluded to some of the reports. Financial constraints may lead to dilution of the recommendations in the strategy on the basis of the minimum that can be resourced and being delivered. Workforce issues, as I said, there's a national shortage of children's nurses who lead on and deliver the bulk of palliative care to our children. There's a lack of the sitting Legislative Assembly since January 2017, so we have no leadership or drive at government level at the moment. So Brexit, what is that going to mean? We don't know. Who knows where that's going to leave us? So within this challenging context of care delivery, are we letting down our children and families and denying them the care our own strategy recommends? I believe that our health and social care trusts are doing our best we can with the resources available, but ultimately we have not introduced the recommended new method of service delivery, which is in our strategy. So then having a look then, what are our strengths? We have committed, motivated multidisciplinary workforce within the field of children's palliative care. The strategy was created with a full range of professional and public consultation and articulates exactly what we desire to achieve for our children and young people with the life-shortening and life-limiting conditions. So the challenges, palliative care is not being optimised in the absence of leadership and drive to implement the strategy. And just we wonder, is it going to become another strategy to sit on a shelf? How do the children and families who contributed to developing the strategy feel about that? I wonder, have we considered that? We're still some way from achieving the aim of high quality, safe, sustainable and appropriate palliative and end-of-life care to ensure best outcome for our children and families. I'd like to thank you just for your attention.